The Naperville Eldercare channel is brought to you by Kathy Wetters and the great folks with Right at Home of Chicago's southwest suburbs. Today's guest is Nancy Warabi, owner and therapist of In-Home Counseling for Seniors.
Welcome back to the Naperville Eldercare channel. Thanks for joining us today. Our guest is Nancy Warabi. She's the founder from In-Home Counseling for Seniors. Welcome, Nancy.
Thank you. I'm happy to be here.
We're happy to have you. Could you just tell us a little bit about yourself and how our viewers can benefit from your services?
Sure. My agency is In-Home Counseling for Seniors, and that's exactly what we do. I started the agency to provide services to people who have difficulty getting out of their homes, people who perhaps have lack of access to transportation, they have disabilities, they have psychiatric issues that make it hard to go out to a clinic to receive mental health services. So we go into the home. We have an agency that consists of licensed clinical social workers, and we go all over the Chicagoland area.
And where is your office located? Like, primarily, are you north or like near in the city, or?
My home office is up in Lake Villa. Actually, we just moved to Antioch.
Okay, but then you have like the network of like all of your counselors are virtually everywhere.
Yes.
Yes.
Yes, we have currently 94 providers. We cover a territory of 8 counties. So they are all independent contractors, and so they're kind of little self-serving areas. So they would take a territory around their home and provide services for Naperville or for Joliet or Rockford, and travel outside of their home.
Perfect. And we know that it's, to provide that consistency, it's good to have somebody near their home. So
yes, and that was one of the reasons, is because they become the expert for that area. They're able to refer out to other community agencies, and they know the people in that town.
Right. Yeah. That's how we are too. So I know you're really passionate about this, but what got you started with this company? Like, what made you start?
Well, it was interesting because I've always loved serving the underserved, so to speak. And I like home visits because you're able to find so much more about a person and their needs and their issues by going to where they're at. So I had been doing home visits with developmentally disabled adults. And my brother-in-law actually asked me to see his mother, who was an agoraphobic. And I said, absolutely.
And what is that, an agoraphobic?
An agoraphobic is someone they develop a phobia where they don't want to go outside.
Oh, okay.
They increasingly become isolated, and so they're not going to the store. She was not even walking her dog, and she had a dog. So I provided services, and after a while, it never occurred to me that was a service that was covered by insurance. And after a while, I said, what happens to people who can't leave their home? And I started researching, and I found that there were services like in-home counseling in other states, but I didn't know of any in Illinois. So I found out that Medicare covered it, and I just started.
Yeah, tremendous need for it.
Yeah. So we used to be Lake County Counseling for Seniors, and then before I knew it, I started getting calls elsewhere.
Sure.
So.
Well, because there is such a need for it.
There's a huge need.
Yeah. And so how can in-home counseling help somebody? Like, I know that there's like that social stigmatism about like mental health in general, and so a lot of people are reluctant to go to a counselor, but we know that it's really helpful. But can you explain to the audience how it is helpful?
Oh, absolutely. And absolutely it is stigmatized to go see a counselor. And so in a certain sense, that works in our favor because we are on a more personal level coming to where they're at. They're not actually having to acknowledge that they need help by going into an office, by making that call and going in to a clinic. But we can help people who have depression, anxiety, grief and loss, those people who are taking care of a loved one and they're dealing with caregiver stress, people who have a family member who's ill, people who are suffering from any kind of health crisis, any kind of stressor. They just lost their home, they lost their job, they lost their daughter to heroin. And so we come to them, and they don't need a doctor's referral. They don't need to have anybody approve them for the services. If they have insurance and we're on that insurance panel, we can provide services.
Okay. And I know that you're working on something big here in regard to Medicaid. For people that don't have insurance, but like Medicaid insurance instead. Can you tell the listener or our audience about that?
Sure. And it goes hand in hand with my belief that there should be no barriers to care. I believe mental health treatment is something that everybody should have access to. So I didn't want to stop with just Medicare, and I'm on the panels of virtually all the insurances, including the Medicaid managed care plans. When the Affordable Care Act came around, they shifted the health care coverage to managed care in Illinois, part of a demonstration project. And so I'm on the panels for all of those managed care plans. But what you're referring to as far as our big thing is, now I have 94 providers, and I'm in the process of credentialing all 94 for all of those plans. So it is a work in progress.
And really a work from the heart, because
yeah.
to have the perseverance to do that, God bless you, Nancy.
I believe, because the people who have the most need are the ones who have
really
the lack of
underserved,
resources.
Absolutely.
They don't have insurance. They don't have the money to pay for the premiums for a blue chip insurance plan. So they are on Medicaid. And if I can get on a panel, I will try.
Mm-hmm.
I don't care how hard it is. It's going to take a while, but I want people to have access. And if people don't have insurance, then we take sliding fee scale. We will work with them. Some of my providers will do it pro bono. Mm-hmm. We only charge a $10 copay. We don't want people to feel like, oh, you know what, I can't afford this.
Right, yeah. That's fantastic.
So.
And so, who's eligible? I know you said people that have insurance or people that don't have insurance. So basically, anyone that needs help can come to you and pay you $10 and talk.
Right. Well, if they have insurance, and sometimes people can't afford the $10, so
Mm-hmm.
we will cut it down to as low as $1 a session.
Okay.
But if they, and then of course if they don't have insurance, then we'll work sliding fee scale. But all they would need to do is call us. They can call us directly. We have an intake line, or they can go on our website. We have a referral process where they can go on the website and enter their information. Mm-hmm. They can fax us our information, the referral information. So we work with a lot of different ways that they can get services.
And this is your information there, that 847-903-5604 is your number.
That's the direct, that actually is my cell number, but no one can ever get a hold of me because it's the intake line now.
Oh,
so
okay.
they can leave a message with the intake person if they do want to talk to me directly.
Okay.
And that's our website, where you can also provide your information there if you want a referral.
And I don't know if the viewers can see it, so let's say www.inhomecounselingforseniors.com. And so that says in-home counseling for seniors, but every population is served, right?
Yes, and that's another thing. I opened it up to anybody. It really is technically adults, but we actually see kids as well if they are of an age where I can match them to a provider. We have a lot of providers who have experience working with kids. So, we don't advertise that because
Mm-hmm.
not all of our providers perhaps have that experience, but case-by-case basis, the youngest client we have is 11.
Okay. And so you were saying that a doctor's order isn't required.
No.
And so really what you've done is broken down all of the barriers to getting the help an individual needs. And sometimes just talking to someone opens up the floodgates for, vision of new ways to do things, new ways to accomplish things that you've never thought of before. So just, being able to talk that through with someone is so beneficial.
Absolutely, and you look at how stressful it is in these days and times, and you look at a person who has no resources, or they have medical issues and they have financial issues. We want to be able to be a lifeline to that person, and we can work with other agencies. We can be in there at the same time as home health. Or hospice. We can see a person even if they're in hospice.
So
home care.
hospice being end-of-life care, and the home health, how is your service different from home health or home care?
Home health provides the medical social work and the medical care regarding home care. I don't know if I'm saying that right, but a person who is in a hospital and they get discharged because they have an illness or whatever, they broke their leg, they have a hip replacement, they oftentimes need a link. And so a home health agency would come in and they would have a nurse who could check on their care. They would have a person who would be able to bathe them. They would have a social worker who would be in there for a short period of time to see if there's any kind of needs or maybe durable medical equipment. But they're not going to be there long term, and it's going to be primarily dealing with the medical aspects of their rehabilitation, whereas we are going to be for the mental health. And that's why it works so well, because oftentimes the social worker or the nurse or the home health aide is looking at their client and saying, you're not getting better because you're depressed. Your illness is not, your wound is not getting healed because you're depressed, or you're not taking your medications, or you're not bathing properly because you're so stressed and anxious and upset.
And some people may feel like giving up,
right?
Or they may be diagnosed with a terminal illness, and that depression all comes into play.
And they're not getting better, or they'll end up back in the hospital, and the hospital will be like, this person continues to go back into the hospital. They're not thriving. They're not healing, and it's because their mental health is not being addressed.
And so it's a matter of like your outlook too.
Yes.
And sometimes in those situations you feel so hopeless that it's difficult to have a positive attitude to move on.
Oh,
so I
absolutely.
think that by having a counselor, it helps you with the coping strategies to overcome some of those obstacles that you're feeling in your mind.
Right, I agree. And for a lot of people, and especially if a person is not used to being ill or disabled,
sure,
and they're not used to asking for help, or they have an estranged family, it's doubly hard, because all of a sudden you're dealing with this health crisis. And they're like, I've never seen a counselor. Don't call me crazy. And we can go in and we can say, well, no one has to know about this. This is private, and this is to help you recover and be the person that you want to be.
Mm-hmm. And so is it only in an individual's home, or do you go into facilities? Are you able to go see a person, like if they're in, a rehab facility after having a diagnosis, or?
We can go anywhere that a person lives, except there are a couple restrictions, and this is based on Medicare, where we can't go into a skilled nursing facility if they are receiving Medicare rehabilitation services. So for the 100 days that a person may get as a Medicare benefit after a hospitalization, if they're in a skilled rehab, we can't go in, because that's considered a bundled service. And so it's double dipping. But if a person then, after their Medicare benefit expires and they may continue to live in the nursing home for long-term care, we can see them, and we can see them in an assisted living facility, supportive living, independent living, any kind of senior residence, apartment, home. We see people also, if they're homeless, we see people, again, we don't have barriers where, say, if a person is transitional as far as their living and maybe they don't want to meet in their home, we will meet with them at a Starbucks or a park or a library. Because again, we want to respect a person's living environment.
Right. And also, where they're comfortable talking, where they're comfortable communicating.
Absolutely, and sometimes that happens with people who have hoarding situations, where they may be embarrassed.
Mm-hmm.
They don't want someone to come in, and it may actually be a health risk for our
Right.
counselor to come in. And I have providers who are providing counseling services on lawn chairs right outside of the home.
Mm-hmm.
Because that's where they want to meet, that's where the client is comfortable. And again, it's like meeting where a person is at.
Right.
We're not here, we're not the health department, we're not going to bash you over the head for what we see are faults. We're here to empower the person.
Right. Right. And then how long does your service last?
It can last as long as a person wants it, as long as the person is benefiting, as long as the clinician believes that it's medically necessary. So we have clients who are ongoing for years, and you look at a doctor who may see a person who has diabetes for the rest of their life. There really is no limit.
Mm-hmm. And so can you give us an example of like a case where you've really helped someone, like where that it's not that involved, and I don't need names or anything like that, but what's like the most frequently received call that you have for someone to start service?
I would probably say depression. And that can arise from a lot of different sources. Sometimes it's just the cumulative losses of life, and they're aging and they're feeling like they don't have a purpose in life. Sometimes maybe they have a chronic a depressive state that it recurs over and over, and they're managing it maybe with medications, but a stressor occurs, and so they're back down in the depression.
And so depression, can you give us more of a definition of depression? Like, what are the symptoms of depression?
Sure. The two most prevalent symptoms would be a loss of interest in activities that a person would previously find enjoyable, and a sad, tearful, hopeless feeling. So you're crying a lot, you're feeling sad a lot, you're looking at your situation as just gray. So if the person is feeling those two, that really is going to be indicative, but it can also be if there's appetite disturbances, sleep disturbances, people who are irritable, tense, they feel like they're raw, they just are on edge. And that's something that a lot of people don't understand, with the irritability aspect, the anger. People are quick to, because they're just like they have no skin, they're just raw. People who have lack of energy, they just don't want to do anything. They don't want to get out of bed. They don't want to take care of their kids. They feel it's a burden to cook dinner. They feel it's a burden to take their children to school. It's just melancholy. I love that term because it describes it so well, just melancholy. And we have people who have that, I'd say that and anxiety. I probably have to look at our caseload to see which is the predominant one, but and they often are comorbid, meaning they come together. So a person may have anxiety symptoms and depression symptoms, and they can overlap. The irritability also comes with anxiety, the feeling on edge, the worry, the lack of concentration. Both of those are symptoms that occur in both diagnoses.
And so medication might be prescribed. And do you work with a doctor, or are you able to prescribe medication with your license?
I am not, but we will work with any kind of doctor that a client may have. Maybe they have their family physician, or if they don't, we can work with them to see what kind of insurance is accepted by professionals in the area. Same thing with a psychiatrist. Because we're in such a wide area, we don't have a go-to psychiatrist or a go-to doctor, because oftentimes they're not in the area that the client lives in.
Right.
But yeah, we definitely believe in continuity of care and communication with outside professionals, because it's a team approach. And medication often is needed, and that can be difficult, because sometimes in the older generation they're anti-medication, or perhaps they are also taking 10, 15 medications for their physical issues, and so you have to be very careful to, okay, are they going to add another medication, and how is it going to interact with their other health issues? So we always defer to the medical professional.
Right. It sounds so complex, you know, but I guess that's part of it, because we're individuals. You know, so everybody has their own needs and you know, issues, so to speak. So.
And then you throw in maybe the cognitive issues with a person who may be having signs of dementia, or maybe they have Parkinson's or vascular dementia, or maybe they have some of these other illnesses that can affect a person's mental health. So that's one of the things that I like to do is when we come in, we do evaluate how is their medical condition, and maybe they need to have an evaluation, because sometimes the depression and the anxiety may be an offshoot of what is going on with their physical health.
Right.
So.
Excellent.
So hand in hand, and that's why, I mean, that's my hope in this country, is that we realize that our physical health, the medical model, can incorporate the mental health aspects, so that a person can be considered as a whole.
Right.
Mind, body. Mind, body, spirit.
Yeah. And I don't know, I guess that's common for a lot of other cultures, you know.
Yes. But holistic.
Exactly.
Eastern medicine, definitely. I think there are definite signs. I think we're moving in that direction. Definitely less of a medical model and much more integrated, and I even like the terms integrated care program that they have with Medicaid, because it does. It's integrated.
Yeah.
So I'm hopeful.
Excellent. Well, that means I guess you're not depressed.
Well, no, but you know what, and I have to say that it's like everybody has emotions, and I think that's part of one of the issues, is that people have emotions, and people get very afraid of emotions, because in this society people are told that they should be happy all the time, but no one is happy all the time.
Right.
I mean, it's a continuum, and so there are people who are happy and sad. I could be happy, sad, angry, frustrated, miserable, ecstatic, all in the same day, and that's normal. But in this society, it's like, well, something must be wrong. Or if I do have a depressive symptom because I had a bad day, people are like, well, snap out of it. Snap out of it. Take a happy pill. And it's like, no. And so people then learn to feel badly about their emotions, and they hide it.
Right.
And
we were talking about that, the emotions buried alive never die.
Right.
You know, and so they're manifesting that feeling, and so it's coming out in another way.
And then they start becoming ill in other ways, or they start turning it on their kids, or kicking the dog, or not taking care of themselves, or eating too much.
I think that's the number one signal,
drugs,
isn't it? Like the number one sign is if you're kicking the dog. Call the counselor.
I agree. And dogs are so helpful. I mean, really. I mean, dogs are therapeutic. Animals are therapeutic. So, yeah, if you're kicking your dog, then you're kicking your therapy.
That's right. Absolutely.
Then call us.
There we go. There's the plug. So what number would they call you at, Nancy? Tell us again.
847-903-5604.
Great.
And so there's a phone tree there. We have several people. Cherish Reinwald is our client services director. You can talk to her directly on option 3, but any of the options, there's a live voice. You can talk and get help.
Excellent. So thanks so much for being our guest today.
You're welcome. Thank you, and it's a pleasure.